So nausea and vomiting is obviously a very common symptom in advanced cancer, but it's not as common as we once thought. So we used to think it was one of the top 3 symptoms, but actually these guys in 2011, Blair et al., they showed in a systematic review that actually pain, fatigue and breathlessness are in the top, they're the most common symptoms. And nausea and vomiting are actually pretty far down the list. Obviously, they're very distressing to patients. If you split them up, nausea is more common than vomiting. And actually, that figure 71% applies to all people that are dying, so not just cancer, but non-malignant disease as well. So 71% of people in the last 1 to 2 weeks have nausea or vomiting. Just to remind us for a moment that unpleasant as it is, obviously it evolved as a protective reflex, so it can be quite life-saving, and it's there to protect us from ingesting toxins. Sympathetic vomiting was very important to our ancestors, so when we were hunter-gatherers, if a person picked a poison berry and ate it, then it started making them sick, and all the people around them became nauseous and started vomiting as well. And obviously, so that's sympathetic vomiting. Obviously, that was an advantage to the whole group. So when, James will remember this from his time at the hospice, but when we evaluate nausea and vomiting, we use the same process that we do for every symptom. So it doesn't matter if it's bleeding, fitting, pain, breathlessness, nausea and vomiting. We use the same process, and that process is said to be sequential and synchronous at the same time. So sequentially, you ask obviously closed questions about the characteristics of the symptom. And they will obviously be different symptoms, but different questions for each symptom. And then synchronously in the background, you're doing 3 other things. You're thinking about what the cause is, you're thinking holistically and thinking about what the non-physical things are, the psychological things, and then you're thinking about the mechanism. And in the case of pain from a month ago, you'll remember that when we think about the mechanism of pain, it's all about trying to determine whether it's a nociceptive or a neuropathic pain in the first place. So for nausea and vomiting, we do something a little bit different. So if we think first of all about the sequential bit, now Socrates is the mnemonic that the kids these days come out of medical school knowing for pain. So Socrates is the mnemonic for pain questions. And I've kind of a little bit clunkily tried to put that into, it's a bit shoehorned really, into the symptoms of nausea and vomiting. It kind of works, but the R isn't so good. So the R's a bit tenuous. So the first thing is obviously to determine that it is coming from the stomach, so that you're not talking about expectoration. So you ask questions initially just to determine that it is vomiting, obviously. You want to know when it started. You want to know if the onset was about the time that you started that new drug, for example, or when somebody got a chest infection. You want to ask what the vomit looks like, whether it's feculent, whether it's coffee grounds, whether it's undigested food, whether it contains bile, etc. And then the tenuous bit, and it's actually one of the most important bits, you want to ask about how much nausea there is. And before I did palliative care, I didn't realise that was an important thing. But actually, in terms of determining the cause, what the cause is, that bit's really important, because some reflexes have very little nausea and some have a lot of nausea predominating, and that will help you decide what's causing it. So obviously associated symptoms, you're going to want to ask about abdominal pain, bowels opening, fever, etc., etc. Temporal factors, so how many episodes a day, how many times is the person vomiting, what makes it worse, is it made worse, for example, by eating, is it made worse by that PRN oromorph that you prescribed, and how difficult is it for the person, because people have there's a big variation into how people cope with nausea and vomiting. Some people hate it and other people cope with it very well. Obviously, you then want to examine, not forgetting that you shouldn't do a PR in somebody on chemotherapy because of the risk of neutropenic sepsis. And investigations are really important. So in a hospice unit, for example, if somebody had a new onset of nausea and vomiting, we'd almost always do blood tests. So you definitely want to look at someone's renal function, their U's and of course their calcium level. So malignant bowel obstruction, people always think it's commonest in bowel cancer, but it's actually commonest in ovarian cancer. So usually in ovarian cancer, it's because of the multiple peritoneal mets, and it's actually up to 42% of people with stage 4 CA ovary, and less commonly in colorectal cancer. So you get abdominal pain 90% of the time. 70% of the time there will be abdominal colic. But 90% of the time there will be a visceral pain from the actual tumour itself. And obviously the obstruction can take place at different levels. It can be inside or outside the bowel. It can be partial or it can be complete, and it can be continual or intermittent. So the typical picture that we see in the hospice is a lady with ovarian cancer, multiple peritoneal mets, and she's going in and out of partial obstruction. About a third of the time, the malignant bowel obstruction resolves on its own, presumably because things have just shifted about. So it's worth remembering that before you sort of rush in with your steroids or talking to the surgeon. And we can divide the causes up in the same way that we could nausea and vomiting. So directly caused by cancer, not directly caused by cancer. If not directly caused by cancer, then is it debility, a concurrent illness, or something to do with treatment? So what happens in malignant bowel obstruction? Basically, the human bowel did not evolve to be able to cope with mechanical obstruction caused by a fixed immobile lesion like a cancer. So where the physiological processes, because quite a lot goes on when we've got an obstruction, where those things were adaptive for our ancestors, they are maladaptive for people with cancer. And the way I like to think about it is very simple, but basically if you imagine yourselves as cavemen or cave women, and you're really hungry, so you haven't eaten for days and days, maybe even a week, you're starving. Suddenly your tribe catches a dinosaur and it's time to have a feast. So you gorge yourself on bits of dinosaur, great chunks of dinosaur, and unfortunately one of those chunks gets stuck in the bowel and starts to change your body. So the body does three things immediately. The first thing is that the mechanoreceptors and the chemoreceptors in the bowel send a message to the brain and tell the brain to stop eating dinosaur so you don't have any more. The next thing is that the bowel produces masses of fluid to try and flood the area and wash the dinosaur downstream. And the third thing that happens is the bowel contracts more strongly to try and push it down. And with luck, the dinosaur shifts and you live to hunt another day. But these things, although they're really good for ingested dinosaur, they're not good in the case of a patient with cancer. So, of course, this is where it all goes horribly wrong. So in cancer, even though there's very little throughput, or no throughput at all, the bowel continues to contract more strongly with more and more uncoordinated peristalsis. So then the bowel starts to distend, and as it distends, it secretes fluid, and you get into this vicious cycle of distension and secretion, where more secretion obviously creates more distension, creates more secretion, etc., etc. And eventually the bowel wall will become damaged, and when the bowel wall starts to get damaged, it actually triggers off the inflammatory reaction, and then you get the whole sort of activation of cyclooxygenase, ending up with prostaglandins, which are really potent secretagogues. And then on top of that, you get poor drainage, venous drainage of that bit of the bowel, and you get hypoxia, and hypoxia triggers the release of VIP. And VIP causes more edema and more secretion. So the whole thing goes round in a vicious circle. Eventually, fluid and electrolytes will be sequestered in the bowel, and eventually you'll become hypovolemic, and then that's when a person goes into multiple organ failure. The first one is usually renal failure because of reduced renal blood flow. Sepsis occurs because of increased intraluminal pressure pushing the bacteria out, and also because of perforation and gangrene. I think the most important thing that I want to get across about what I've talked about tonight is in nausea and vomiting, remember the four most common causes, so gastric stasis, malignant bowel obstruction, biochemical causes and drug causes. Never use metoclopramide and cyclizine together, and try and use a mechanistic approach when it comes to choosing your antiemetic. The mechanistic approach, as opposed to the empirical approach when you're picking an antiemetic, is when you try and determine what the cause of the nausea and vomiting is, which you should be able to do about 90% of the time, remembering of course that 25% maybe of the time there's going to be more than one cause. And then you try and remember which pathway that particular cause uses, then think about which neurotransmitter that part of the pathway uses, and then pick an antiemetic that best targets that neurotransmitter. So when we're thinking about people with malignant bowel obstruction, the course can be quite variable. There was one RCT done in 1997 by Wolfson et al. That showed that if you have surgery or if you don't have surgery, it doesn't make much difference. The median survival is still about a month, and that ties in with our experience in specialist palliative care. I have to say sometimes people survive a lot longer, and that can be a surprise to some. So we do have a few people who survive for several months on the medical management of malignant bowel obstruction without any surgery. Tonight I've talked about malignant bowel obstruction, constipation and nausea and vomiting, but obviously there are many other symptoms in advanced cancer in the GI tract. The most common is probably anorexia. So anorexia is present in about 78% of people with advanced cancer. The anorexia cachexia syndrome is very interesting and very difficult for people. So this is basically a negative energy balance that happens in cancer that is driven by two things. It's driven by anorexia, so a reduced calorie input, but it's also driven by factors that alter our metabolism, and those factors can be produced by the person themselves. So for example, interleukin-1, tumour necrosis factor, basically cytokines, or they can be produced by factors that the cancer itself produces. So for example, proteolysis inducing factor. And these things set up this negative energy balance. And the key thing about anorexia cachexia syndrome is that you lose muscle mass as much as fat mass. So different to the type of weight loss that we see in starvation, for example. The management of anorexia cachexia syndrome, and indeed of anorexia, is all about the progestogens and the corticosteroids. So the drugs that we most commonly use are magestrol acetate, medroxyprogesterone acetate, dexamethasone and prednisolone. There was a Cochrane study looking at magestrol acetate quite recently, and this looked at a large number of people, 4,000 or so people, and 35 studies, and that showed that about 1 in 4 people that are given magestrol acetate will have an improvement in appetite. About 1 in 12 people will put on weight, usually around sort of 2 kilos. But actually, none of the drugs that we use for anorexia are particularly helpful for the weight loss aspect, because they tend to make people put on fat and fluid as opposed to muscle mass, and that can make matters more difficult because people then have less mass but more weight. Dexamethasone is used very commonly, and the optimal dose is about 3 milligrams. We mustn't forget that it's fluorinated, so it will cause muscle catabolism and a breakdown of muscle. So for that reason, if you're using it long term, then it's probably best to use prednisolone. But the overall advice is that if somebody has more than a few weeks to live, then maybe go for one of the progestogens, so magestrol acetate or medroxyprogesterone acetate. Hiccup is actually a very common symptom in advanced cancer. The commonest causes tend to be gastric stasis, which is probably the most important, brain causes like brain tumour or sometimes after stroke in fact, biochemical causes like low calcium, low potassium, high glucose, low carbon dioxide, so metabolic causes, and also certain drugs cause hiccup, particularly opioids and alcohol in fact. When we try and manage hiccup, there's several drugs that we can use. So we can either use a prokinetic like metoclopramide to take the dopamine break off the stomach if we think, for example, that gastric stasis is the cause, or we can use muscle relaxants such as the benzodiazepines and baclofen, or we can use centrally active drugs such as gabapentin and valproate. So death rattle is a very common symptom at the end of life, and it's very distressing for both relatives and staff. In one study, about 50% of relatives and staff found it very distressing. We do have evidence that the patients that are suffering from death rattle are not actually bothered by it, and a large part of the management is going to be reassuring relatives about that. There was one Cochrane review done recently by Biwi and Richard Hillier, and that actually found that we don't have evidence that either non-drug or drug methods help with death rattle. However, because it's so important that we are seen as trying to do something sometimes, then we probably will continue to use drugs. And those drugs tend to be the anticholinergics. So the ones we use most frequently are glycopyrronium and hyoscine hydrobromide. And another study showed that they can be effective about a third to a half of the time. Glycopyrronium does not cross the blood-brain barrier, so we use that in people who have maybe been confused and before that point. But there is some evidence that hyoscine hydrobromide is quicker to actually take effect.